تفضل دكتور.
Good morning, and it's a great pleasure to be with you again. Just to be sure, you can hear me well, right?
نعم.
Okay.
Sure.
The first case, so in general, before we start the cases, today I'll show several cases, nearly 6 cases. We will discuss the case together. Meanwhile, I'll be highlighting the most important concepts. And for the sake of time, I won't be presenting any slides, but I'll focus on the most important points while discussing the case. So this is the first one. The history is a 60-year-old male presented with a productive cough with no improvement after antibiotics.
Yes. Frontal radiograph of skeletally mature 6 years old patient.
If you can, please show me your thought process while we're describing. I want to see your approach, please.
Yes, I start by the lung fields first. Both lung fields are symmetrical in size and no loss of volume. I see no loss of volume. Both costophrenic angles are clear. Both hyla are clear. There is some opacity seen in the left, in the apex of the left lung.
Good. Before that, sorry to interrupt you, but can you give me just a few seconds description about the technical adequacy of the radiograph?
Okay.
So we said the projection is frontal projection.
Yes.
Is it likely to be posterior anterior or anterior posterior?
Posterior anterior.
Why?
The patient who come from regarding the ribs, if I start counting the ribs, الcardiac shadow looks normal in size, not enlarged.
This cardiac shadow will be influenced by the projection, so it's not going to be our guide. Most likely it's the scapula. If the scapula are more likely to be clear, it's clearing the lung, not superimposed on the lung. This most likely posterior anterior. So in the anterior posterior, sometimes you see the medial border of the scapula nearly here. So, but most likely this is a posterior anterior. What other elements do you check?
نعم.
What other elements regarding technical adequacy of the radiograph? Instead, in addition to the projection and orientation, here we see it's right side, so we're oriented now. What
Yes.
else?
The trachea is supposed to be in the midline between the two medial ends of the clavicle. So I assume there is no rotational.
No. So what if the trachea is displaced by a pathological process, but the medial ends of the clavicle are equidistant from the spinous processes? That's our guide. So
Yes.
the medial ends of the clavicle should be equidistant from the spinous processes, which is fine. So there is no rotation, and we can see the disc here, intervertebral disc. So the penetration is good. And for the inspiration, the posterior ribs at least 10. So here, this is the 10th rib. Here we start counting. That's good inspiratory effort. And also the anterior ribs, 1, 2, 3, 4, 5, 6, at least 6 touching the diaphragm, midclavicular line, has 7. So we have good inspiratory effort. So that's technique is acceptable. Everything is fine. And we go back to your description, please. So there is a lesion in the upper zone on the left side, right?
Yes. There seems an opacity in the apex of the left lung. Regarding the costophrenic angles, I see them clear, no pathology. Visualized bones looks normal. I didn't see any pathology in them. Regarding the mediastinum, looks not shifted to any place, to any side. Cardiac size looks normal. As I
normal, yeah.
Both hyla look clear. Apart from that opacity, I didn't see any abnormality.
Okay, so we checked the lungs, the pleural space. We checked the mediastinum. And also we check the hidden areas, APCs, hilar regions, the area behind the diaphragm and below the diaphragm. We check the shoulder area, the neck for any, sometimes surgical emphysema or something else, or a lesion coming down from the neck, and the bones. And there are no lines or tubes or anything. So let's go back to the lesion. So how can we further characterize this lesion here?
The lesion, I see a neurobronchogram in the lesion.
It is in the lesion or just bypassing the lesion? It is, the lesion is, I can see the lung markings are passing smoothly through the lesion. The lesion is not disrupting the course of the lung markings, right? Looks like it.
Yes.
And the lesion is not that dense. It's not that radio opaque.
Yes.
You can see the markings. Okay. So how can we know if, how can we get more information about the location of the lesion, whether it's anterior, in the middle, or at in the posterior of the left hemithorax?
We can take, if there's a lateral projection.
No, on this projection.
There are certain signs اللي احنا يعني تبين لنا انه anterior or posterior mediastinum. طبعا هو هذا مو بالهايله. شوف مثلا هو الهايلر اوفرلاي ساين وعندنا السيرفايكوثوراسيك ساين ممكن تساعدنا.
Both are likely
not helpful here لانه يعني بالupper zone هو الليجن.
Any application of the silhouette sign here?
Yes, الاكو silhouetting للسباين يعني الاورتيك نكل يعني ده شوفه نورمال يعني كلير.
Good. Which means
يعني الميدل ميدياستاينم هو الاورتيك نكل طبعا ميدل ميدياستاينم يعني not middle mediastinum.
So it's either anterior or posterior
or posterior. فممكن يفيدني السباين silhouetting with the spine.
That's good. Okay. What else if we need to know if the lesion is pulmonary or extrapulmonary?
يفيدني الانجل اللي make the lesion making with the mediastinum. It's obtuse or acute.
Okay. Which part of the mediastinum?
نعم.
Which part of the mediastinum?
Regarding this lesion?
Yeah.
I think this posterior mediastinal lesion.
Okay. Let me ask you another question.
Yes.
Is there a difference between the superior border of the lesion and the inferior border of the lesion?
Yes, the inferior border of the lesion is clear or circumscribed, بينما superior border تقريبا indistinct.
Good.
يعني I can't see يعني not well defined.
Have you heard of incomplete border sign?
Yes, incomplete border sign. إذا كانت mediastinal mass أو عندنا مثلا pleural mass, not like the pulmonary mass. Pulmonary mass تقريبا تكون complete border. الميدياستينال pleural mass تكون incomplete border.
So it distinguishes between pulmonary and extrapulmonary lesion.
Yes.
And the extrapulmonary lesion could be pleural, could be extrapleural, could be mediastinal, could be in the chest wall.
نعم.
Good. So in this case, why? Because there is the X-ray will be tangential, and there is and the border will be very clear because there is a contrast between this side projected over the lung, but where the lesion is originating, and because it has a wider base outside the lung, we don't see any border.
Yes.
So that's the principle. And so it's a low density lesion, most likely extrapulmonary. How, is there anything we can check to make sure possibly it is not in the chest wall? See, the bones are fine. I mean, there's no bone destruction or something. If there is some tumor or something aggressive in the chest wall, we have some destruction, so we can say at least in the chest wall destroying ribs or something like that, but we don't see that. So rather than doing a lateral chest X-ray, what would be your choice next in terms of imaging?
I could recommend CT of the chest.
Okay. Two. So this is CT scan. you can describe.
Well, this is a multi-sectional CT of the chest with the IV contrast. ممكن أشوف بس البلمونري ويندو. هو يعني ممكن أنا شفت الليجن بس يعني for checking.
For sure.
وممكن أرجع للميدياستانال ويندو. So obviously there is a well-defined low attenuating anterior mediastinal mass. ممكن أقيس الدنسيتي مالتها but it looks to me a fat density.
Same as subcutaneous fat, right?
Fat density as the same as the subcutaneous fat. It's well defined, not causing any mediastinal shape. I think this is يعني ممكن أخذ differential بس on the top ممكن تكون lipoma. Lipoma. And since it's capsulated it's lipoma. ممكن تكون أيضا mediastinal lipomatosis but يكون هو يعني not defined or well capsulated.
See, so now, as we can see, as we go inferiorly, see, this is the border with the lung that shows here.
Yes.
And this is where the lesion is based, outside the lung. See, it's broad, and there is no superiorly. We can see any border here. And so, is it? Can we have a hint if it is pleural or mediastinal lipoma?
I think this is medial. I don't know.
Yeah, it is the most likely mediastinal because it is continuous with the mediastinal fat, and the internal memory vessels are slightly displaced laterally compared to the other side. So there's a fat here and fat there. So it's a mediastinal lipoma. Is it benign or you see any suspicious?
It looks benign to me. The suspicious features of lipoma يعني تخليني أفكر well differentiated liposarcoma مثلا إذا كان عندي enhanced septation, thick septation, enhancement of the septa or nodularity of the septa, إذا كان the fatty component less than 25% of the يعني mass، أو إذا كان invasion أو ill-defined border, invasion of the surrounding structure, ill-defined border. ممكن أفكر
do you think that this lesion is responsible for the presentation of the patients of productive cough with no response to antibiotics?
Yes, it could be. يعني نسوي في mass effect. هو اللايبوما هي benign lesion. مو significant mass effect. ممكن تكون asymptomatic.
Yeah, I mean, most likely it's not. I mean, because it's a small size. It's not compromising the lung, and doesn't produce a productive cough. There's some thickening of there's some thickening with the bronchial walls here. Possibly the patient had
bronchitis or infection.
Yeah, bronchitis or something. But now we don't see any real consolidation. There's some atelectasis here. So it's a benign lesion, and it's a mediastinal lipoma. And the most important here is just to make use of the silhouette sign, make use of the incomplete border sign to get more information from the radiograph. Thank you so much, Doctor. That was excellent. I appreciate it.
Thank you.
The next case is, let's see if we can have a third-year student for this one. Any volunteer?
دكتورة تبين؟
نعم أستاذ.
موجودة، تفضل.
شكرا.
أهلا دكتورة. I just want you to describe the radiographs and your approach to them.
Okay. Okay.
This is sorry about that. So the history is it's a 41-year-old male presented with a fallen outstretched hand, has bone tenderness at the distal radius, and they're wondering if there is a fracture there.
Okay, this is a frontal and lateral radiograph of the right wrist. About 43 years old, right, Doctor?
41, yeah. No problem.
Yeah, okay. Okay, I can see abnormality and in the scaphoid bone, in the right scaphoid. And there is a bony part of the bony lesion that's separated from the scaphoid bone on the right side. And also the scaphoid the borders seem to be sclerotic, and it's stickily attached to the distal end of the radius. So I think this is the type of the avulsion fracture of the scaphoid.
Okay, that's good.
Yeah.
First, I want you to tell me what features of proper alignment you want to see on the dorsopalmar and lateral radiographs of the wrist. So for the dorsopalmar one, what kind of alignment? There are like lines that you can use. Do you remember the name of them or the description of them? No worries. So there are lines called Gilula lines, which outline the proximal border of the convex or proximal border of the proximal row of the carpal bones here, and the other second line goes here, the convex border of the proximal row. Proximal row, and the other one, the anterior, is also the third one is at the posterior aspect of the hamate and capitate. So these lines should be parallel and regular. Do you see any kind of disruption here?
Yes. In the proximal and middle carpal row, I can see discontinuity, particularly in the line connected to the lunate and the scaphoid in these two lines. Yeah.
So what about the alignment of the lateral radiograph?
Although this is, I think the carpal row is not.
I'll show you. This is the
really
lunate.
seen. Yeah, this is lunate.
This is
It should be vertically oriented, the cap of the lunate upstairs. But actually, I think there is a lunate some sort of tilted to the posterior.
Yes, there is a volar tilt of the lunate here.
Yes.
There should be a straight line from the radius centrally, goes through center of the lunate, but the lunate is tilted, and also the capitate is slightly tilted, but still there's no dislocation here. So if we can, I'm going to ask you on the lateral, do you see signs of perilunate dislocation or lunate dislocation?
Actually, if there is a perilunate dislocation, the carpal row the lunate is the same line, the carpal row will move, the other carpal row.
Yes.
Yeah, but here the lunate is in the same location, also the carpal row the same location, but the lunate have moved its alignment to somewhat posterior. It is in its location actually. So maybe go with some sort of DC, I think, dorsal intercalated segmental instability.
Yes, you're right.
Something
That's more
like that.
Yeah, I agree with you.
Which is associated with the scaphoid fracture, likely. Yeah.
I agree with you. Let's go back to this one here.
Yes.
So we have now my question.
Yes.
What kind of joint changes here? Are they degenerative changes or inflammatory changes?
Yes, I see some sclerotic changes actually at the end of the scaphoid only.
Yeah.
The other carpal bones remain in their normal end plate is normal, and there's no sclerosis, no osteophytes, no erosion actually. So
no erosion. I agree with you.
Yeah. There's some point osteopenia, but it's not so aggressive, I think.
Yes.
Yeah.
I agree with you. The thing is that we have, especially at the radioscaphoid articulation, we have severe osteoarthritic changes that degenerative.
That's right.
But the loss of joint space totally, we have subchondral process. Here between the lunate and the scaphoid, we have some.
We have this space, it is widened actually.
And the space is more than 3 millimeters.
Yes.
Yeah.
So it's
scapholunate
dissociation, yes.
Good. And also, this disruption of the Gilula lines here, see this, the capitate is migrating proximally. Also, the scaphoid is migrating proximally against the radius. So we have proximal migration of the capitate and scaphoid, severe osteoarthritic changes involving the whole radioscaphoid articulation. Yes. We have also osteoarthritic changes involving the capitulonate articulation here.
Yes, some changes, yes, that's right.
Okay. The slight osteopenia is likely related to the disuse atrophy because the patient had a chronic degenerative problem and a previous injury, a previous fracture, although we didn't have any previous imaging. So in this case, I will show you something now. Right, get that here. This is the scaphoid, and this line is parallel to the lunate center. This line is going through the axis of the scaphoid. So this angle is more than 60. This is scaphoid
lunate line.
This is indicative of rotary subluxation of the scaphoid, which is an element of dorsal
intercalated segmental
instability.
instability. Yes, it should be less than 60. Yeah.
Yes. In addition to that, if we measure also the capitolunate angle,
it will be more than 30, I think. It will be more.
Yes.
Yeah.
And this one should be parallel to the same one here. This one is less, even if we try to force it a little bit, but it's less. I think, yeah, I measured it previously. It's nearly 28. So it is approaching the definition of DC, but it goes with that in that direction. Maybe after a while, it's going to be more than 30. But if it's more than 30, more than 60, that's DC. If it is more than 30 and here less than 30,
VC.
it's going to be VC.
Yes.
Okay, now, so what's your diagnosis?
As we said, dorsal intercalated segmental instability, and since there is a sclerosis and abnormality in the end of the scaphoid, and distance between the scaphoid and lunate has been increased, so I think this is a fracture of the scaphoid with avulsion of the part of the bone, and there is sclerotic changes and scaphoid lunate dissociation, and there is some sclerosis and thinning, and also we can say some smaller like normal this scaphoid. I don't know how to describe it, but let's go with the scaphoid lunate advanced collapse, I think, dissociation and advanced collapse.
Excellent, that's the right diagnosis. It's scaphoid lunate advanced collapse complicating severe osteoarthritis.
Yes.
The thing is that so the elements are severe radioscaphoid osteoarthritis, capitolunate arthritis, carpal instability because of the disruption of the scapholunate ligament and the dissociation here, proximal migration of the capitate and scaphoid, and nearly DC here. These are elements of the scapholunate advanced collapse complicating severe osteoarthritis. The same changes could happen after a fracture, a fracture of the scaphoid with non-union. It's called also SNAC, scaphoid non-union advanced collapse. This case was meant to show the approach to the radiograph of the joints, and you should have a system, and you look at the joint space, loss of joint space, changes going with degenerative disease versus inflammatory disease, erosion versus buttressing changes like osteophytes and secondary sclerosis. Also, there's a CT here, but we don't have the time, but just 1 second. Let me show you something here. See, there are many subchondral cysts.
Yes, that's right.
Also shown, especially in the scaphoid, as you can see here. This disruption of the radial aspect of the scaphoid thought to be chronic, and these well-corticated bone fragments are also related to previous injuries. So no acute fracture found here, but it's a severe osteoarthritis with SLAC. Thank you so much, doctor. That was excellent.
Thank you.
Next one. Okay.
دكتورة راغد سعدون.
نعم
راغد.
صباح الخير.
صباح الخير، حتى تعلقين بنتي على الكيس.
إن شاء الله.
صباح الخير دكتورة.
صباح
So the history
النور.
for this case is a 75-year-old male presented with sudden abdominal pain overnight, associated with vomiting, globally tender abdomen, and that tenderness was worse centrally in the abdomen. So I'll show you this scan, and you can start describing the type of scan and any visible abnormality.
نعم.
Okay, Ustad, I'm presented with abdominal CT, axial abdominal CT with IP contrast.
Which phase?
Arterial phase.
Portovenous or arterial?
Portovenous.
No, yeah, okay, good.
بس العفو أستاذ الهيستوري ما كلش سمعته لأنه شوية الصوت
Okay,
راح.
again, yeah, a 75-year-old male with the sudden abdominal pain last night, vomiting, global abdominal tenderness, worse centrally.
Okay. There is ascites seen.
Good. Ascites here, perihepatic and intrahepatic,
Okay.
also perisplenic, and also some, just to help you, there's some fluid also in the pelvis.
And the
Okay.
pelvis. Yeah.
Main abnormality.
Okay. Also striking abnormality, I detected there is small bowel dilatation.
What's the maximum diameter of the small bowel?
3 cm.
Good. This is more than that, I can assure you, okay? At least some of them. Okay. What else?
Well, there is bowel, small bowel look grouped together on the right side. I think it's internal hernia, maybe.
Okay, main abnormality. Before going into the cause of the, what do we call this abnormality in general? So dilated bowel above normal limits, certain part of the bowel. Is it a small bowel or large bowel?
Small bowel.
Small bowel. Part of it is dilated.
Part of it, yes.
Let me show you.
Type of internal hernia, I think.
Before that, please, I'm going to show
Yes.
you the distal. This is the ileocecal junction.
Okay.
See, the distal ileum is collapsed, right?
Yes.
Good. I'm going to show you the large bowel. So this is the rectum, right?
Yes.
Follow the rectum. This is the sigmoid. The sigmoid has some diverticula with no diverticulitis, no problem. This is a descending colon, transverse colon. Okay. Follow it now, ascending colon, everything is good. So it's small bowel, part of it is dilated.
But closed lobe
Distally collapsed,
obstruction.
proximally dilated. What's that? Diagnosis.
It's internal hernia, right paraduodenal internal hernia.
No, it's a small bowel obstruction.
Okay.
Okay. What kind of obstruction is this? So where's, can you see the transition point or points here? So why do we look for a transition point?
To exclude if there is a mass or.
That's good. That's one thing. Okay. So let's follow the bowel again. So this is the stomach. Can see the stomach, and here's and this is first part of the duodenum, and going down the second part, going vertically down, and then this is the third part, going transverse direction, right? And this is the fourth part, starts from here. And if we follow these loops here, they're dilated proximally, continuous with the fourth part of the duodenum. So the jejunum is dilated, and then we reach this area here.
Yes,
transition
it's
point.
two sides.
Two transition points.
A transition point, yes.
What does that mean?
Maybe it's due to adhesions.
No, if we have one transition point, okay, we look at it, we see if there is a mass causing the obstruction, if we see any intussusception causing the obstruction. If there are two transition points, it could be a volvulus. If there are two transition points, could be also another part, another description that also, the volvulus is also part of it, where we have two transition points and dilated bowel between the transition points and dilated bowel proximal to the first transition point.
Proximal, yes.
There's a term for this.
It's a closed lobe obstruction.
Excellent. Closed lobe obstruction. So we have volvulus is also a type of closed loop obstruction, right?
Yes.
We have cecal volvulus, we have sigmoid volvulus, and also other kind of volvulus, you know, somewhere else possibly. So, but this one has 2 transition points and a cluster of dilated small bowel loops. What's the significance of closed loop obstruction here? Why do we need to decide if it is a closed loop or open loop? Very important point.
يعني to rule out the ischemia.
Excellent. Because the high risk of ischemia, whenever, so it's very important point, is like an emergency. High risk of ischemia when they have a closed loop obstruction because of the restriction of the blood supply. And what can you give me more information about the assessment for ischemia in these obstructed bowel loops here? What features you can look for?
The bowel wall enhancement.
Good.
And
enhancement could be low or absent, or could be irregular enhancement. What about
usually it's look normal.
Now it's good. There is enhancement maintained, yes. But there is some
also
heterogeneity here, and there is what.
Gas.
Okay, you're right. If there is mural gas, pneumatosis in the wall, yes. This signifies what?
If there is gas in the wall, which it's confirm the
there's necrosis in the wall. Well, yes. What if there is pneumoperitoneum?
This perforation.
Good. Do you see any?
It's emergency, a surgical emergency.
Do you see any extra luminal air? No.
No.
So there's no extraluminal air. So there's no pneumoperitoneum, no perforation at least. Is there any necrosis in the wall? We don't see pneumatosis, so there's no necrosis in the wall. Is there air in the mesenteric veins or portal veins inside the liver, portal venous gas? No. So there's no evidence of clear necrosis, but still there is a high risk of ischemia. Irregular enhancement, thickened wall. So what's the normal thickness of a small bowel?
Less than 3 million.
Good. I'll try to measure something. Nearly 5.
So it's thickened.
Yeah, there's thickening of the wall. Some sort of irregular enhancement, although not all of the loops. What else? Indicating high risk for ischemia. Look at the mesentery. What's happening in the mesentery?
We notice there is engorgement of vascularity.
And fat stranding?
Yes.
Edema, hazy. Okay, so irregular enhancement, thickened wall, fat stranding in the mesentery, engorgement of the vessels. So there is high risk of ischemia, in addition to the fact that it's a closed loop obstruction.
Yes.
Okay, what do you do next?
It's emergency referral.
Good. You call them directly. You just call them. This patient needs to be operated upon as soon as possible because of the high risk of ischemia. And you said something about internal hernia, right?
Yes.
Do you think this closed loop obstruction led to internal hernia or just adhesions?
I think it's internal hernia, transmesenteric.
Why? The patient didn't have any previous history of operation. What's the most common type of internal hernia?
Transmesenteric, then right paraduodenal.
Paraduodenal is the main, and left more than right. So, but usually, if it's an internal hernia, we wouldn't find the cluster of obstructed loops here. You find it posteriorly.
Yes.
Nearly retroperitoneal, go the anterior renal space, because they go. So for the left paraduodenal, most common, there's a defect or sometimes a congenital defect, or sometimes it could be in the mesentery of the descending colon. So the cluster of bowel loops goes here in the anterior paraneal space, not anteriorly here. And in addition to that, at the anterior neck of the hernia, you'll find the inferior mesenteric vessels.
Yes, correct.
This is the inferior mesenteric vessel, okay? The vein and artery. So the lobes of Powell should be here. Okay, that's an important point. So it's not a left paraduodenal. For the right paraduodenal, also the cluster will be inferior to the level of the third part of the duodenum, and also expected to be here posteriorly. And another important point, you should look at the superior mesenteric vessels, and the cluster of obstructed loop should be posterior to it, deep to it. And these vessels should be at the anterior neck of the hernia, not posterior. So it is not internal hernia. And this patient was operated upon and found to have
So it's adhesion.
Related to adhesion. And as we saw here, there is a segment of ischemic bowel, ischemic loops that were resected, and the patient had a ileostomy after that. So there was ischemia, and it's a closed loop obstruction, and that's why we need to make sure that we diagnose it and convey the findings as soon as possible to surgery, because there's a high risk for bowel ischemia. There are other incidental findings. If we just for just a few seconds, I'll show them to you. There's a hernia here, and we talked about the diverticulosis. No. What's this thing here? This could be a chronic omental infarction. See the wall and see some calcification. And here, 1 and 2, these are indirect inguinal hernias. So one of them with the fluid going toward the side of the scrotum, and this thing. Follow it up. This is the vessel, this vessel. Going up and going into the left renal vein. That's varicocele. Anyway, these are incidental findings, not related to the pathology. So thank you, doctor. That was excellent. The closed loop obstruction due to adhesions with bowel ischemia. Thank you so much. The next one.
دكتورة إيمان حميد.
نعم أستاذ، صباح الخير.
صباح الخير. حتى تعلقي لنا بنتي على الكيس.
This is the fourth case. Alan, doctor. This is the fourth case. This is an 84-year-old female presented with chest pain, pallor, tachypnea, and shortness of breath.
Chest X-ray, frontal view, showing reduced lung volume, left-sided.
You said frontal view, but it's mentioned here AP.
AB.
So you can make use of the different any markings we can. So we're oriented as AP projection. Yes, please go on.
Reduced left-sided lung volume and mediastinal widening, obliteration of the left costophrenic angle.
Good. And by the way, sorry if I'm not looking at the chat, because I don't. We're just very short time, so apologies if I didn't pay attention. So yeah, we had mediastinal widening, and the patient had chest pain. What else? Can I get more information from the radiograph?
A prominent cardiac size.
Yes, yeah, for sure. I agree with you. Although it's AP, but still there is, because the size is very big here. And so mediastinal widening presented suddenly with chest pain in an old patient.
Large aortic knuckle. Possible.
Can you see this line here?
Yes.
What's that?
Calcification?
Yeah, it could be intimal calcification, right?
Yes.
But the opacity goes beyond it, lateral to it. More than that. And can you see the borders of the aortic knuckle clearly? Can you see?
obscuring.
Yes, you can't see the pulmonary artery separate, right? The window is obliterated between the aortopulmonary window. So L definition of the aortic knuckle, we have some opacity extending beyond the aortic intimal calcification, and sometimes with definitely we had, of course, as you mentioned, mediastinal widening. So what's the likely thing happening now here?
I think there is aortic dissection.
In progress.
That's good. So there is an aortic dissection as an element of acute aortic syndrome, right?
Yes.
Yeah. What other signs we may find? I'll tell you. So if there is, as we mentioned, the signs, definition of aortic knuckle, widening with the mediastinum. Sometimes it's more than a third of the radiograph. Sometimes more than 8 or 10 centimeters. Also, if we can be sure that the trachea is deviated, the depression of the left main bronchus. Sometimes we can see an apical cap because of the blood going, following or tracing the extrapleural space. And also we can see like hemothorax, and we can see the obliteration of the, either angle, mostly left. So these are all signs. And by the way, the chest radiograph is not sensitive or specific for acute aortic syndrome, but it's a guidance, okay? So in this case, I can tell you that the reporting doctor here didn't pay attention to the mediastinal widening. And since the patient has shortness of breath and the pain, they thought it's a pleural pain. So they did CTPA, CT pulmonary angiogram. They were suspecting pulmonary embolus. So have a look, please.
Axial CT scan of the chest with IV contrast study showing enlarged of the aorta with the retroaortic hypodense
So this is a pulmonary phase. This is the pulmonary angiogram.
yes.
And the most important, I can tell you there's no pulmonary emboli. Okay, that's good.
Okay.
But there is a clear abnormality here.
Extending aorta increase in size and with the wall thickening and retroaortic hematoma.
Good. So there is what element of acute aortic syndrome we can see on non-contrast or in a CT scan that is not an aortogram like this one.
See intramural hematoma or if there is any calcification in the
That's
wall.
good. Yeah, there is intramural hematoma, thickening and high density, especially of the ascending aorta, right? And there is definitely there is a stranding and some high density fluid in the mediastinum, as you can see here, and that's what we saw on the X-ray. Here. So see, this is the calcification.
Yes.
And this is what we saw. So just a correlation. In addition to that, we have mediastinal hematoma, we have intramural hematoma of the aorta, ascending aorta, and in addition to that, we have
a pericardial fusion.
Yeah, and it's same high density. That's blood.
Density hemopericardium.
Okay, and we have also fluid in the pleural.
Lot of fusion.
Is expected to be with the same process. So in this case, we didn't see emboli, but we're suspecting acute aortic syndrome with at least intramural hematoma, of course. So
urgent,
what to do next?
Urgent refer the patient for cardiac surgery for surgical drainage of hematoma.
No, but we haven't verified yet acute aortic syndrome. What kind of it is? Dissection, something else, right?
Yes.
So what proper evaluation of the aorta here is through cardiac gated aortogram, right?
Aortogram. Okay.
CT aortography here. Okay. So this is what was done after that. What does it show?
Increase aortic diameter and penetrating ulcer, I see.
You're right. So this is penetrating ulcer here.
Yes.
And there's penetrating ulcer here, rupture, forming a pseudoaneurysm here. And with all this blood, and definitely, since we established there is intramural hematoma, that's acute aortic syndrome. And what classification? Is it A or B?
Classification A.
Yeah, it's Stanford A because involving the ascending aorta.
Ascending
So in any case, we have an element of, we have intramural hematoma, that's acute aortic syndrome, A. So that's mainly surgical or medical?
A, surgical.
Surgical. And in addition to that, we have penetrating atherosclerotic ulcers with pseudoaneurysm formation due to rupture, mediastinal hematoma, pericardial hematoma. We established all of these, and definitely we're going to call them, tell them this is urgently need to be treated surgically. What other complication we need to check before, and put them in the report?
I should check if there is any coronary vessels.
Yes. Can you tell me if they are patent or not? So this one here, this guy here.
Stenosis of the right coronary.
Okay, there is some slightly, but it's patent. The main point is that especially if there's dissection, the dissection could extend into the origin, the ostia of the coronary arteries, and is block them. So we need to make sure they are patent. So we didn't see any dissection flap, right? But still, we can comment and see there's patent. This is right coronary artery and patent left.
Okay.
See left anterior descending and circumflex. You can see it, right?
No.
It's going down. So patent coronary arteries. There is a pericardial hematoma, mediastinal hematoma, type A intramural hematoma, and ruptured also type A atherosclerotic ulcers. This patient should be treated surgically, but unfortunately, because of the old age, the patient is fragile and has multiple comorbidities. So she was treated, conservatively because they couldn't operate on with such a condition. But the prognosis wasn't good for that patient. So thank you, doctor. So this case was presented to show how we can properly evaluate the radiograph and then evaluate cross-sectional chest imaging when it comes to acute aortic syndrome. That's very good. Thanks so much, doctor. Let's go to the next one.
Correct.
Welcome.
شكرا دكتورة إيمان. ننتقل إلى دكتورة سارة عباس من مركز مدينة الطب.
السلام عليكم.
وعليكم السلام.
حتى تعلقي لنا بنتي على الكيس.
تمام.
Okay, I'll be showing you this case. This is a 49-year-old female patient presented with episodes of olfactory hallucination and altered hearing for 4 months, associated with expressive dysphagia.
Okay.
I'll show you. This is you can start describing.
Yes, I'm presented with the axial MRI T2 sequence of the brain. The most striking finding, there is abnormal high signal intensities involving the insular cortex and insular cortex and I can scroll down through the study. Yes, the anterior temporal and more up, I think inferior frontal, maybe. Yes. This is abnormal high signal intensity in T2 involving this region. I can show, I want to see the flare sequence. Yes. Yes. Also, abnormal high signal intensities of the insular cortex.
Insula, the temporal
anterior temporal, yes.
Yeah, this is the operculum, which covers the insula, part of the temporal lobe. So the operculum is made of 3 parts. So the frontal, this one,
Yes.
Temporal, and posteriorly parietal.
Yes.
Here. So in addition to the insula, you're right. And look at this picture image and tell me, is it mainly involving the white matter or cortex?
Mainly cortex, look like cortex mainly.
Look
Yeah.
again.
Okay, subcortical white matter more likely.
Yeah, see
Yeah.
the cortical line?
Yes, this one I can see.
Also, the cortical line here also.
Yes, okay.
Then mainly based in the white matter. So you'll see it's expanding here. And I'll show you other sequences.
Yes, I want to see the contrast and the diffusion weighted image. Yes. Okay, there is a high signal intensity involving the ADC and the diffusion weighted image, so it is look like not restricted.
Yes, there's no significant
No
restriction.
significant.
I agree with you. And this is
Contrast.
This is T1 pre and post.
Yes. Also, no enhancement, no significant enhancement. I can't see
That's
any
good.
enhancement, and there is no mass effect, no peri-lesional edema, no mass effect, no shifting with midline.
And just one thing I want to show you. T2 is the flare. Have you heard of mismatch sign?
Yes.
Do you see something here?
Abnormal high signal intensity in flare than in T2.
Is it a positive mismatch sign or not?
Mismatch sign, yes, it's abnormal high in flare, low in يعني less than in T2. Which
Yeah, for mismatch sign, the central part of the lesion should be suppressed compared to the T2, where the only peripheral or margin will be hyperintense. But this is not happening here, right?
No, I can't see.
Yeah, still the same as like all hyperintense and this all. So mismatch sign, if it is positive, what does it tell us?
Astrocytoma, most likely.
What grade, the WHA grade?
Maybe يعني low grade, يعني grade
2.
2, yes.
Okay, good. Now, so we didn't have enhancement, we didn't have obviously necrosis, we didn't have restriction, diffusion. We see like nearly uniform with no mismatch sign. So what's your diagnosis finally?
Maybe a low grade glioma.
Right.
Yes.
So diffuse astrocytoma, glioma. According to the new description, a new WHO classification, they didn't. They kept only 2, 3, and 4 grades. Yes. So is it grade 4?
No, there is no edema, no significant enhancement, and no restriction.
No necrosis, no. For grade 4, that's a glioblastoma. Before they used to call it glioblastoma multiforme. Now they removed multiforme.
High-grade
glioblastoma. High-grade glioma only called the glioblastoma and has necrosis, heterogeneity in general, composed of necrosis, sometimes hemorrhage. Definitely, there is large areas of enhancement, usually peripherally because of this central necrosis, and diffusion restriction, and it's going to be aggressive and older age, so that's not it. 2, we have the mismatch sign. It doesn't show here. And here's some slight or negligible diffusion or something like so. It's between 2 and 4. That used to be called anaplastic astrocytoma, but that was removed. Even the term is not present anymore in the classification. So it's called astrocytoma IDH mutant WHO grade 3. And this patient was operated upon. And the pathology proved, anaplastic. That's a grade 3. Candid. Just mute. Can mute your microphone, please. So so this was a grade 3 astrocytoma. I'll ask you a couple of questions now.
Yes.
Regarding the differential diagnosis. So how do you differentiate between this and ischemia?
Ischemia, according to the stage of ischemia, if it's acute, it will be restricted on diffusion weighted image.
Good.
is the most important thing. And if acute, if subacute, 3 days, the restriction will be reduced and start to take enhancements. After 1 month, it will be a chronic, so no restriction more than that.
That's good. The history of this patient is 4 months,
Yes.
right? Not acute, right? And clearly, the cortex, I mean, essentially, ischemia should involve the cortex, right?
Okay. Yes.
So mainly here, white matter than cortex. Also, definitely, this could be a part of the territory of the middle cerebral artery, but usually sometimes, we can see the lentiform nucleus, the head of caudate and everything. They're not involved, although not necessarily. What other differential diagnosis you have in mind?
Firstly, I thinking about herpes, but it is not detected also, and no enhancement, and it will be more involved the inferior frontal and temporal lobe.
You're right, and also insula. Is it necessary to have a restriction or enhancement in encephalitis?
Enhancement is variable, but restriction it must be.
And usually, no, not must.
Uh-huh.
Only in the
Okay.
not necessary. In advanced cases, you can see diffusion, but not necessary. And it's usually bilateral, asymmetrical, right?
Yes.
Exactly. And also we can use the history, fever, confusion, few days.
Previous history of yes.
And what about DNET?
DNET, it's okay. It's subcortical also involvement, more pupilly in appearance. Also can be slight of edema with it, some sort of edema. It's also
Yes. Usually it is smaller, cortical based. Usually it's cortical lesion, bubbly appearance, as you said, and usually it's smaller and in the temporal lobe and in younger patients. This patient is 49 usually. Another thing, just I want to add regarding the high grade versus low grade glioma. Also, we can use perfusion study to see relative cerebral blood volume, which is higher and higher grade. We can use spectroscopy. Spectroscopy, there will be high choline, low NAA, high choline to creatine ratio, and high lactate and lipid peaks too. While low-grade glioma have increased myoinositol and myoinositol over choline ratio too. So it's a collection of signs or features we can use. And this patient has anaplastic astrocytoma, and the patient was treated with surgery and then chemotherapy and radiotherapy. I think this is scan post-treatment.
Yes.
Craniotomy here, and this is a post-contrast image. We can see the post-resection, and we don't see any element or any enhancement or nodular.
Residual.
No evidence of recurrence. Okay, thank you so much, doctor. I appreciate it. So it's really good. And the final case.
شكرا دكتورة سارة عاشتي دك. ننتقل إلى دكتورة صفاء عدي من مركز الكاظمية. دكتورة صفاء.
السلام عليكم.
عليكم السلام. حتى تعلقي لنا بنتي على الكيس، تفضل.
Okay, أهلا دكتورة. This case is for a 38-year female presented with chest pain and shortness of breath.
تمام.
You can start describing.
Okay. PA chest radiograph of a skeletally mature patient.
See the edges, the medial edge of the scapula?
Yes, I can see the medial edge.
Yeah, it's most likely rather AP rather than PA, right? Unless it is
AP?
mentioned. Yeah, because you said usually with the PA, you have the scapula, going laterally clearing the lungs. But anyway, so the frontal projection, we are oriented.
Yes, frontal projection.
What's the most significant?
The most significant finding is that enlargement of the cardiac shadow. Yes, with the globular shaped heart.
Right.
Yes, and abnormality of the right cardiac border
Mhm.
with the bulging right cardiac border. I can see that the lung fields are clear. The left costophrenic angle is clear, but the right one, I think it is obliterated.
Right.
Yes.
The shape of the heart here, suggestive of what?
Pericardial effusion.
Right. That's good.
Yes.
So in this case, they, I think they suspected also pulmonary embolism and the CTPA, but I will show you a CT done a few months before the presentation.
Okay.
The patient presented with right iliac fossa pain back then. Look at the right iliac fossa.
Yes.
I'll show you the structure here.
There is a high density structure in the right iliac fossa, mostly in the appendix. Can I see the area again?
Yeah.
Yes, with a dilated tubular structure. So it is mostly an appendicitis with appendiculis.
Yes, there are
I
two.
can see facet rounding. Yes, facet rounding in the area. And
Yeah,
signs of
dilated
inflammation.
enhancing wall, surrounding fat stranding, appendicolits. So it's a classic case of acute appendicitis with no perforation, no rupture. So the patient had acute appendicitis back then, and at the most superior image, you see this.
Yes.
So there is some.
There is a high density fluid in the
Okay.
pericardial space.
Okay, so
Yes,
there's
so it
fluid
is.
in the pericardial space back then, but that was not, of course, not related to the main abnormality, and I'm not sure whether that was commented upon or not, but it was there. So the important of this is looking back and checking previous imaging. So when you suspected pericardial effusion here, and you go check any previous imaging, whether it is a radiograph or any cross-sectional imaging, and you see this, you said, yes, there was a small amount of fluid, and now it mild pericardial effusion, and now it's increasing, and that's possibly the case. But they, because of the chest pain and shortness of breath, and the patient was pregnant at that time here, so they had to do CTPA, CT pulmonary angiogram, because of the suspected pulmonary embolism, because, patient is pregnant and they had, they suspected pleural pain, and they did this. So what do we see here?
Just 1 minute, please.
Sorry? Sorry, can you go again? Can you come again? Can you see if there's any pulmonary emboli?
I can see a pulmonary embolus.
There's no pulmonary embolus, right?
Yes.
Okay, that's good. Well, what are the positive findings here?
There is right-sided pleural effusion.
Good. because of the size and the shape of the heart, we thought there might be some pericardial effusion. But what's in the pericardium now? What's in the heart or around the heart now in this image?
Sorry, just 1 minute.
Okay.
There is a low density lesion, nearly water density, in the right side of the, at the right side of the heart.
Do you still think it's water density?
No.
Okay, it's
Yes,
heterogeneous.
high density. Yes.
There's heterogeneity there. It's heterogeneous, but it's not water density. Okay.
Yes, right. It is extending, related to the right side of the heart.
Yes.
Could be a pleuropericardial cyst.
Again, we said there's high density, or 50 something soft tissue elements. So why do you think of a cyst? Look at 67.
Yes.
So there's some enhancement, there's some heterogeneity inside the lesion. And look at this. This is the epicardial fat. Disappears here. But still the lesion is likely, remains more likely like within the boundaries of the pericardium. Or do you agree it could be originating within the pericardium, right?
It could be an aneurysm of the right ventricle, possibly.
If it is aneurysm and this is the right ventricle, the contrast is only here. Unless it is completely thrombosed, but you don't see any,
yes.
Right? Because there's contrast in the right ventricle.
Yes, I thought it may be an aneurysm with a large thrombus, maybe.
No.
Explaining there is no contrast. It is so it is like a soft tissue mass lesion.
Yeah, right.
Yes.
It's compressing the right heart chambers,
yes.
ventricle and right atrium. As also there's some sort of compression the superior vena cava here. What do you need to see from from the scan else rather than mediastinal window?
The lung window.
That's good. Okay.
Yes, there are multiple lung nodules. Possibly.
Yes, I remember this. Sorry, I'm interrupting. I remember this
Yes.
case was discussed in the MDT meeting, the multidisciplinary meeting of lung cancer, and the radiologist who reported it didn't have any clue what's going on, and they just saw this weird mass here. But I'm asking you, after seeing the lungs, what do you think?
I'm thinking about metastasis, and possibly these are metastatic deposits from the main mass, which could be malignant mass.
Yeah, so see the fusion here and everything.
Yes.
Bones. No aggressive bone lesion, I can tell you.
Yes, I can't see any
So
abnormal
if
bone.
they are metastases, any specific sign regarding the appearance of these metastases that could give you a clue? Look, for example, to this one.
Yes, I can see that they are surrounded by a ground glass opacity.
Excellent. Yes.
So it means that it is a hemorrhagic lesions.
What types of malignancies can give rise to hemorrhagic metastases?
Melanoma, I think.
Yeah, that's possible. Yeah.
Yes. Thyroid masses, renal cell carcinoma.
Okay, good. And since we have this lesion here.
Yes.
So what could it be?
This, because of its site, I think it could be a malignant mesothelioma.
Yes. Okay, if it's mesothelioma, where? I mean, you cited the pericardial serosal lining, and then unlikely. Well, I mean, especially with the metastases, mesothelioma, does it produce hemorrhagic metastases?
No.
Yeah, not likely.
Yes.
Okay, so hemorrhagic metastases, this could be sarcomas, right?
Yes, it could be an angiosarcoma.
You're right, yeah. Angiosarcoma, choriocarcinoma.
Yes, choriocarcinoma.
Can cause hemorrhagic metastases. You mentioned also Kaposi's sarcoma. You mentioned melanoma, you're right. What if these bilateral lung lesions are not malignant? What if they are benign with this appearance? Forget about the mass in the pericardium. I mean, solid surrounding
yes.
ground glass halo sign.
It could be like a fungal infection.
Yes.
Yes, angioinvasive aspergillosis.
You're right. And possibly also other fungal infections. Sometimes, you know, in rare cases also septal and black blood, but mainly it's angioinvasive aspergillosis. What if it is not malignant and not infectious? Like inflammatory lesions, inflammatory conditions could cause such appearance? Example?
Yes, such as Wagner granulomatosis.
You're right. Yeah, polyangiitis
with possible cavitation.
That's possible also. Eosinophilic lung disease also. If it is, I mean, single lesion, pulmonary infarctions could also produce that. And if it is also just one lesion, solitary lesion, adenocarcinoma, lung adenocarcinoma could produce that, because mainly adenocarcinoma start as ground glass, right?
Yes.
Sometimes they develop solid elements within them, so the appearance could
could be similar.
Could be similar to that. You're right. So we have hemorrhagic metastases and aggressive lesion. And by the way, this lesion, I could show you the PET scan. On the PET scan, this lesion showed heterogeneous avid uptake. And after that, it was biopsied with CT-guided biopsy. What do you think? Can you give me a final diagnosis? You said angiosarcoma, right?
Yes. Yes, I think it is the most suitable one.
Yes, it is. This case proved to be, after histopathology, pericardial angiosarcoma with metastasis to the lung. And that's what I suggested MDT, because they said, okay, this could be something we don't know, and these could be eosinophilia or vasculitis. I told them it's always good to have a unified diagnosis, right? One diagnosis linking everything. So one diagnosis linking everything was this. And after the MDT, they arranged for the biopsy and the PET-CT, and it proved to be, as I suggested, pericardial angiosarcoma with hemorrhagic metastases.
Okay.
Yeah. And the patient underwent after that. She's going through chemotherapy. And the last time I checked, unfortunately, after a while, these metastases have grown, and she's not doing well, unfortunately, now. This is one of the recent radiographs showing increased diffusion and also, more white out to the lower right hemithorax. So that was our last case. We wanted to show the differential diagnosis for lung lesions with halo sign, including malignant and non-malignant, also including infectious and non-infectious. And we had a look at the appearance of this unusual lesion in the pericardium, and we had a look at CTPA, and also the importance of checking previous imaging. That's very important to look for any useful information. I enjoyed being present with you today. Thank you so much, and I hope it was helpful. And I urge you to go on, just to look at the recording and just do more search and look for more information regarding the signs and differential diagnoses and the diagnoses we discussed this morning. Thank you so much. Let me know if you have any questions.
شكرا جزيلا أستاذ حمد.